Hi, I'm Orrin Devinsky from the NYU School of Medicine, and I'm here to present on the GW Pharmaceuticals Epidiolex trials. Now, these trials have occurred over the course of several years and have now included both open-label trials and randomized Phase 3 double-blind trials. I'm going to summarize mainly the data from the open-label trials and then give a bit of data from the newly released Dravet syndrome study, which was a double-blind randomized placebo-controlled trial. So to begin with, this second slide summarizes our open-label experience with cannabidiol, or Epidiolex, which was presented at the American Epilepsy Society meeting in December of 2015 in Philadelphia. And I should start out by just saying that Epidiolex is a commercial product produced by GW Pharma, which contains 99% cannabidiol in an oil base. Cannabidiol is a very lipophilic molecule, so it needs to be dissolved in an oil, and that is the way it was given to these children and young adults. So for this first set of data that I'll be presenting, it is the largest and most complete set and included 313 children treated at 16 epilepsy centers over a little over a 2-year period. These children and young adults included 261 individuals who received the Epidiolex for at least 3 months of continuous therapy. And that's important because that's the standard time duration that we look for in the FDA trials for both safety and efficacy. In the trials that I'm presenting here on the open label data, there was a wide range of patient ages between 4 months and 41 years of age, with a mean age of 12 years old. The doses that were used varied widely, from a low of 2 milligrams per kilogram to a maximal dose in some sites that got approval from the FDA to go to higher doses of up to 50 milligrams per kilogram per day. But I should emphasize, for the vast majority of patients, the maximal dose was 25 milligrams per kilogram per day or lower of the Epidiolex. And for this group of the overall 313 patients, epilepsy diagnoses was unknown in 19%, was Dravet syndrome in 17%, and was Lennox-Gastaut syndrome in a few percent lower. The median convulsive seizure frequency in patients across this study was 48.8%, and in Dravet syndrome patients, 52.3%. In Lennox-Gastaut syndrome patients, the median reduction of atonic seizures, the most paradigmatic and signature seizure type for that syndrome, was 71.1%. Now, the big caveat with this study, and I'll repeat it again, is that it was an open-label study. The physicians knew what they were prescribing and giving to the patients. The parents and patients who were aware of it knew what they were getting. They were getting the actual labeled compound in a jar that said Epidiolex. So everyone knew what was being given and what was being received. We had no placebo group in this, and there was no blinding. So we have no idea from this data set what the placebo response was in this group of patients. Among all the patients that we treated and that we had the duration of time of 3 months or longer, 47% of them had a greater than 50% reduction in seizures. As far as seizure freedom, 9% of patients overall and 13% of patients with Dravet syndrome did obtain seizure freedom during the study. Now, one of the things that emerged from this open-label experience is that patients who were on clobazam and then Epidiolex or cannabidiol was added to the therapy, we did see increases in sedation, and in select patients for whom we don't have enough to say this definitively, but we've seen this. Dr. Elizabeth Thiel published this in Epilepsia. Dr. Dan Friedman, one of my colleagues here at NYU, published this as an abstract and presented it at the American Epilepsy Society meeting a year before, is that when cannabidiol is added to clobazam in a patient who's already taken clobazam, we see elevations in the N-desmethyl metabolite of clobazam. And that metabolite, we believe, is biologically active with regards to both efficacy and toxicity. So if a child or young adult is on clobazam and we add Epidiolex to that child's regimen or young adult's regimen, we expect that in some cases we likely may see an elevation in that N-desmethyl metabolite, and that could lead to more tiredness, for example, as a side effect, and potentially could lead to greater effectiveness of the CBD through this drug interaction mechanism. There are some additional caveats about this. There are other drugs that can also inhibit the metabolism of this enzyme that degrades the N-desmethyl metabolite. And so other drugs that may inhibit that include steripental, which is also used in Dravet syndrome, especially in European patients, but in some American patients, and felbamate as well. So it may be patients with Dravet who are on clobazam and steripental, and potentially felbamate as well. We don't have the data yet to confirm this, but we've seen instances where we have not seen an elevation in the N-desmethyl metabolite when cannabidiol is added to clobazam therapy. And that may simply be because in those patients, their N-desmethyl metabolite levels are already quite high because of the co-therapy with a drug like steripental. So that's an evolving story. We need much more data to define it, but it is something to be aware of in clinical practice and also in research methodology studies. So in the presentation of the data at the American Epilepsy Society meeting, we did look at those patients who are on clobazam co-therapy because we think that's an important group to look at. And indeed, there was a somewhat higher rate of treatment response, a median reduction in the convulsive seizure frequency, which for those who are already on clobazam was 56.4% versus 35% at week 12 for those who are not on clobazam co-therapy. And as I said, this we think may be in large measure because the CBD or cannabidiol induces an elevation of that metabolite, which is biologically active. However, clobazam co-therapy effect did not seem to influence the efficacy results in either the Dravet or Lennox-Gastaut syndrome groups, and it may be because some of these patients were already on medications that induced that or inhibited that conversion of that metabolite or other mechanisms. So again, larger data sets will be needed, and we hope the randomized trials will shed light on this as well. With regards to the safety of cannabidiol, the open-label studies also provided some signals that we think were very helpful. Among the adverse events that were seen in at least 10% of the treated patients were somnolence in 23%, fatigue in 17%, diarrhea in 23%, decreased appetite in 17%, vomiting in 10%, and convulsions in 17%. The convulsion is an interesting one in that it's hard to know because we did not have placebo-controlled data. We don't know what the natural history of the epilepsy is in this specific patient group. And so we know for many of the children and young adults who were entered, essentially all of them had very severe treatment-resistant epilepsies. And for those of us in practice, we know these patients have bad days and bad weeks and bad months and good days and good weeks and good months. And for some of these patients, what was listed as a convulsion as a side effect, in many of the investigators' views, we didn't list that as a side effect because we thought that was the natural history of the disorder, whereas other investigators felt that any difference from the baseline period should be listed as an adverse event. So there's a lot of variability in how different investigators interpreted the same observations. And again, I don't think any of us know what the right answer is. This is clinical medicine and how we best attribute things we see to potential causes. With regards to the adverse events, there were 14 patients, or 4% of the overall study group, who had an adverse event leading to discontinuation. And there were 36 patients, or 12% of those treated, who withdrew because of a lack of efficacy. In addition, 16 patients, or 5% of the cohort, reported serious adverse events that the investigator considered to be treatment-related. These included altered liver enzymes in 4 patients. All 4 of those were on valproic acid. Status epilepticus or convulsion in 4 patients, and I discussed the challenges of understanding what the true relationship is. I don't think we can say definitively. Diarrhea in 4 patients, weight loss in 4 patients, and thrombocytopenia in 1 patient, and that patient was also on co-therapy with valproate. Now, I'm going to turn in the next set of slides to discussing the open-label experience that was published in Lancet Neurology in December of 2015. This represents a smaller group of patients and a smaller number of centers, and this was the first set of data that was really curated and annotated that we could go through very carefully, make sure it was highly accurate, that the methodologies were consistent, and so it was able to be combined for publication in a high-impact journal. This was 11 centers beginning in January of 2014 and going through 2015. 214 patients with treatment-resistant epilepsy were enrolled, and this overlaps entirely with the other set of data that I just presented. There were 162 patients who had at least 3 months of continuous therapy for which we could derive good safety and efficacy, or I should say for here, safety data, and 137 of whom we had sufficient data for the efficacy analysis. The mean age in this group of patients was 10.5 years with a range of 1 to 30 years. They started typically at 2 to 5 milligrams per kilogram per day and then were increased mainly to 25 mg per kilo per day, but in a few centers up to 50 mg per kilo per day. And this flow diagram just shows the group of patients who are enrolled. Some were enrolled but did not have 12 weeks of follow-up after their first dose of cannabidiol. 11 stopped before that, 1 due to an allergy from the oil. 1 had elevated liver enzymes. That individual was on valproic acid. 1 had somnolence, and you can see 4 had worsening seizures and poor efficacy, and the family decided instead of waiting, they really just wanted to exit the trial. So there were 162 left for the safety and tolerability analysis, and then we excluded 25 of those from the efficacy analysis for various predetermined criteria. So at the outset, we said we'd be studying children 1 year of age and older. There were several children with progressive disorders, which were, again, exclusion criteria for the main protocol, and they were included for compassionate reasons. And then there were 21 patients who had no convulsive or motor seizures as we define them in the methodology for both the protocol and the Lancet Neurology paper, and you can read that in the methods. And so they were excluded from the efficacy analysis because they didn't meet the criteria of the seizure type that we wanted to count, and that left the 137 for whom we did analyze. So this is a breakdown of the groups by sex, and you can see it was fairly evenly distributed between males and females. The number of background drugs, which ranged in anti-epileptic drugs from 1 to 7, but averaged 3, and again, quite similar in the 2 groups, safety and efficacy analysis groups. Vagus nerve stimulation was used in about 10% of patients, ketogenic diet in about 8 or 9% of patients, and clobazam co-therapy was present in about half of our sample. And then you can see the range of seizure types. There were focal seizures in 36% of patients. There were tonic seizures in 41% of patients, atonic seizures in about 20 to 23% of patients, tonic-clonic seizures in the majority, greater than 50% of patients, and other motor seizures were identified, again, in a majority of patients. The next slide goes over the diagnoses of the patients who were enrolled in the study that was reported in Lancet Neurology, and this includes Dravet syndrome in 20% of the safety group and 23% of the efficacy group, Lennox-Gastaut syndrome in 19% of the safety group and 22% of the efficacy group, and then you can see spread out a number of other disorders from investigators who categorize the diagnosis as minimal brain dysfunction, CDKL5, tuberous sclerosis, epilepsy with myoclonic absences, febrile infection-related syndrome, Ohtahara, Jevons, and several others. So it was a wide range of patients, but Dravet and Lennox-Gastaut were the two most common. Here is the side effect or adverse event profile of the 162 patients that we analyzed. And you can see on the top, this is very similar to what was reported before: somnolence, decreased appetite, diarrhea, fatigue, convulsion. There were some patients with increased appetite, were the main adverse events in more than 5% of patients. With regards to the serious adverse events, status epilepticus was reported in 6% of patients, diarrhea in 2%, decreased weight in 1%, and then a number of serious adverse events in less than 1% of patients. So I want to finish now with what I think is the most exciting data to share with you. This was recently released as a press release by GW Pharma, and this is based on the Phase 3 randomized placebo-controlled double-blind trial that involved a number of centers in both the United States and in Europe. And this was selectively for patients with Dravet syndrome, with the Epilepsy Study Consortium and Ingrid Scheffer doing the screening to make sure all of the patients fit the clinical and diagnostic criteria for Dravet syndrome. There were 128 pediatric patients enrolled, ages 2 to 18 years. 61 of those patients were randomized to receive Epidiolex or cannabidiol. 59 of them were randomized to placebo, and you can see the mean ages for the groups are essentially identical at 9.7 or 9.8 years. These patients had all treatment-resistant epilepsy. They had an average of 3 concomitant anti-epileptic drugs, and they averaged having been treated with more than 4 previous anti-epileptic drugs. None of them in multiple combinations had controlled their seizures. And the median baseline of convulsive seizures in this group of patients who were randomized was 13 per month. So again, a high seizure frequency for a very severe disorder. With regards to the safety, overall, Epidiolex was well tolerated, and these data closely parallel the open-label experience that we had. Adverse events that were recorded in 10% or more of patients included somnolence, diarrhea, decreased appetite, fatigue, pyrexia, vomiting, lethargy, upper respiratory tract infection, and convulsion. 84% of all adverse events were rated by the investigator as being either mild or moderate. Among the serious adverse events, there were 10 in the Epidiolex-treated group and 3 in the placebo group. With regards to discontinuation due to adverse events, Epidiolex patients, 8 of them discontinued due to side effects, and in the placebo group, 1 discontinued due to adverse events. With regards to the efficacy, which is really the exciting data, because we had no idea what the placebo rate would be, so it was a 14-week treatment period. For the patients who were randomized to the Epidiolex or CBD therapy, there was a 2-week titration period in which they went from no drug to 20 milligrams per kilogram per day. I do think, in hindsight, this was a relatively rapid taper, and probably a lot of the adverse events could have been reduced or even prevented had we have gone with a slower titration period. But having said that, there was a 2-week titration period. People on placebo were titrated to more placebo during that time. People on Epidiolex were titrated to more Epidiolex. And then there was a 12-week period of continuous treatment with the same dose of either Epidiolex or placebo. The median reduction of convulsive seizures, which was our primary outcome measure, over the 14 weeks. Now, the data would actually look better if we just looked at the 12 weeks where the patients were actually on the target dose of Epidiolex, 20 milligrams per kilogram, but the data I will present is the agreed primary outcome measure with the FDA, which was based on the entire 14 weeks, which includes the titration period. And for Epidiolex, the median reduction in convulsive seizures was 39%, and for placebo, it was 13%, and that was significant at a level of 0.01. We are very encouraged and excited by these results. We're very happy that the placebo response rate was relatively low, which we think has much to do about careful selection of patients with Dravet, careful determination of the seizure type that we would count, in which parents and caretakers could be reliable and consistent. And we hope that the second study, which will be a dosing study of placebo versus 10 milligrams versus 20 milligrams per kilogram per day, will produce similar results, and that hopefully this medication will be available to children with Dravet syndrome and can improve both their seizure control and their quality of life. Thank you.